All right, so I'll go ahead and get started. So for exam two, we have the concepts from weeks 4 to 6. So 50 questions, 75 minutes to complete the exam. You will have math. Um, and so, sorry, my allergies. I have fall allergies, and for some reason they're kicking in a little bit early. All right, so I will share my screen. All right, so for the concepts for week 4, we had the special vulnerable populations, so your pregnant adolescents, your LGBTQA population, mental illness, alcohol, tobacco, and other drug problems. For week 5, it was hospice and palliative care, death and dying, religion or faith and spirituality, and ethics. And then for week 6, it was occupational health, environmental health, barriers to learning, and then reinforcing health education. So those were the topics that were covered for weeks 4 through 6. Um, so we'll just go ahead and get started. So again, week 4, we had the special vulnerable populations. Um, and, so generally speaking, vulnerable populations usually have poor health outcomes compared to others in terms of morbidity and mortality. They also have a high prevalence of chronic illness, right? Hypertension, higher level, like hypertension. They have higher levels of communicable diseases like tuberculosis, hepatitis B, your STIs, upper respiratory tract infections like flu. They also have higher mortality rates compared to general population, right? Because of, poor living conditions, diets, health status, crime, violence, domestic violence, that kind of thing. So looking at pregnant adolescents, we look at what are some of the, special considerations that we, would be concerned with when we talk about pregnant adolescents. Any ideas?
Like them still being in school. Um,
Yeah.
Yeah, like trying to keep them in schools. It's one of the big things too.
And
Um,
prenatal health, well, prenatal care.
yep, prenatal care.
mm,
So, think about you as a community health nurse or a school nurse, right? Making sure that they're scheduling those prenatal appointments as priority. Um, you know, get that early and continuous prenatal care. That's, we know that that's super important for maternal as well as the child's health. When we look at pregnant homeless teams, can't even say it, pregnant homeless teens, right? They're even a bigger challenge, right? They have higher rates of sexually transmitted diseases, higher incidences of, addiction to drugs as well as alcohol. Obviously, their nutrition status is going to suffer. Um, they also will have higher rates of poor birth outcomes. So being homeless is the most dangerous of those, right? When we look at pregnant adolescents, um, they tend to also seek, health, not so prenatal care later on in their pregnancy, which we know that that's a huge concern, right? Especially if, you look at STDs and other issues with them. Um, and that's not just an issue during the pregnancy, right? That's going to continue after they have the baby too, right? Unless we can find them some sort of, um, temporary housing, shelter, that kind of thing. Um, and then postpartum visits, their primary goal of a postpartum visit is to assess the knowledge regarding normal growth and development. Lack of familial support is a significant factor contributing to postpartum depression in adolescent mothers. So really, how much do they understand the needs of that newborn, or that infant, that, I mean, think about it. Do you guys have kids? I don't know if you guys have kids, right? Even if we're prepared for kids, right? They still present challenges, right? You never know what's going to happen. And imagine not having any kind of support or even being homeless, right? These are things that, working with the community, we may have to try to find some assistance for them. Um, think about, just the frustrations. You have that crying baby, right? And you can't get the baby to stop and you don't know what's wrong. Um, and so making sure that they, really understand the growth and development and what to expect. That helps to avoid any unrealistic expectations, any frustrations, which could potentially lead to child abuse. Um, so again, that primary goal is going to be, during that postpartum visit is to, assess what they know, regarding normal growth and development and kind of what to expect. We look at poor teens, they're nearly 3 times more likely to drop out of school, as their non-poor counterparts. When programs that assist mom to complete her education are instituted, chances are increased for a better future, right? That improves healthcare, right? As well as lifestyle for that adult, for the mom and the child. So one of the big things too is we want to try to get them to complete their education, right? So what resources can we provide or help them to find, to help them complete their education? Think about it. Just think about why you're in school, right? You want better things for yourself as you get older. And so it's the same thing for them, right? Getting their education is super important. Um, sorry.
But I
When we,
wanna, I'm
oh,
sorry, I did
you're
want to
fine.
know, in case we saw something like it on the test, like what type of resources might we expect? Because the education system isn't really like how it used to be. Like, depending on where you are, there's not always like night schools or, you know, different means of childcare. So what we would expect as far as like per our materials?
I mean, not super specific, but I mean, just think of some of the resources that are available within the community, right? So we have things like WIC, right? Women, infants, and children that can definitely help with like nutrition, right? Making sure that, mom's getting stuff that she needs, the baby can get formula, and, if that's what, mom chooses. Um, there are things like homeschooling that is available in most areas, right? So that they can, continue their education even while they're out on, postpartum, leave or maternity leave, whatever. So a lot of, homeschooling, we know how important education is, and most areas will have some sort of, they may not have the night schools and things like that, but they generally will have something like homeschool, programs or even alternative schools, that they can go to. When we look at the LGBTQ, um, plus in population, nurses have an ethical obligation to make sure that we are providing culturally competent care to this community. Um, and so, you know, and it's true, and especially some of the younger nurses, or even some that maybe have not had any experience in these areas, right? They may feel some, we may feel some degree of discomfort, regarding their, discussing sexual orientation with their clients. Right. But we have to, right? That's part of our job as nurses, right? We have to kind of overcome this barrier, especially when we're working with the LGBTQ families. So, we need to provide that safe environment, for them to discuss their sexual orientation. And so it's really important to understand kind of how you feel about it too, right? We all, have our own biases and our own judgments that we tend to make, right? And being able to put those aside when we're working with clients is super important. Um, Homosexual behavior in adolescence is not uncommon, right? And that's the time where they're exploring options, right? They're trying to figure out who they are, who they want to be, that kind of thing. Um, so we really need to, be able to, open up with them, discuss, what's going on. Working with the pediatric population especially is a little bit different, right, than working with an adult population. Um, Adults, not every adult, I'm not gonna say that, but most adults kind of know where they stand, right? Who they are, what they want to be. And adolescence is such a crucial time in anybody's lives, right? Because there's so many things going on, between school and hormones, right? And, trying to figure out who they want to be when they grow up, right? And so it can be a very confusing and a very, kind of wavering time for them. And so having someone that they trust, like a nurse or, another adult is super important so that they can discuss these things. Remember too, with adolescents, anything regarding sex and sex orientation is something that is considered private. You maintain your HIPAA, you don't have to talk to the parents about it. Remember, anything, unless they are telling you that they plan to hurt themselves or others, right? Everything is remain confidential. So we want to maintain that open, non-judgmental um, communication with them. Ask them about their sexual and social history, right? That helps to build the trust with that community. Don't want to make any assumptions about, how they appear, what their sexual behavior is, and use those open-ended questions, right? So, you know, do they have a partner? Are they in a relationship? Who do they call their partner? So we want to, back, when I was younger, right? It was, are you married? Do you have a husband? Right. So we want to kind of take those questions and kind of turn them around so that they're more, I guess, gender neutral would be the appropriate word, right? Um, and that helps to initiate those conversations without assuming, right, that they're heterosexual, right? So if somebody came up to me and said, do you have a husband? Well, I mean, I do, but what if I didn't, right? So that could be very offensive, right, if I had a female partner, right? So um, other things with the LGBT community too, the CDC does provide recommendations on screening and, prevention for sexually transmitted infections. So the yearly screening for HIV, syphilis, gonorrhea, genital herpes, chlamydia, especially if they're high risk, we may have to screen them more often. If they have multiple or, anonymous sex partners or those that use drugs in conjunction with sex, would be at a higher risk, right, for developing those STIs. Um, Mental illness is a big one. We know that there is a huge mental health crisis, right, in the United States, and we need to get, more providers. And COVID kind of brought that out a lot, right? We realize that, especially by putting people in their homes, right, for the majority of the time, realize there's a lot more of a mental health issue, especially even with our younger generations. So general anxiety disorder, just this is a person who experiences persistent, unrealistic, or excessive worry about two or more life circumstances, for 6 months or longer and is exhibiting symptoms. One of the best medications that we have out there for generalized anxiety disorder is Buspar, or Buspirone. Um, Buspirone is one of those really good. It's It's one of the drugs that we can use for patient. I know this pharmacology, but it's one of those medications, right? Where when we look at some of the other medications like your Valium, your Ativan, right? We don't want people taking those for long periods of time, right? They're addicting, they can lead to abuse, right? There's a lot of things that can go on with those medications. Buspar is one of those really great drugs that can be used for long-term anxiety. It works when we look at Buspar, whereas Ativan Valium, you get an immediate effect. Buspar does take a little while, so it can take a week or two for it to build up into the system to really, produce its effects. But it can be safe for long-term use. So somebody that has generalized anxiety disorder, that's a great medication for them. Don't have to worry about the abuse potential and, everything else associated with it. It cannot be used for, treatment of paranoid thought disorders, drug, alcohol withdrawal, schizophrenia, those kinds of things. So again, anxiety disorders generally is what your Buspar is used for. With phobias, everybody has a phobia, whether it's a spider, whatever, right? We all have something that we fear. It's an excessive irrational fear of an activity, of a situation, of an object, which can lead to avoidance or extreme anxiety. That can lead to, interfere with normal responsibilities and routines, even some of our ADLs, depending on the situation. PTSD is characterized by a previous event that involved threatened death or serious injury, either to self or others, during which the individual experienced intense helplessness, or horror. And so remember, it is, an event. They didn't necessarily have to be involved in the event. They could have used the event. Sorry, hold on one second. They could have witnessed the event, right? And it still caused that intense fear. So people, I think back to, September 11th, even people that were not there and, weren't in the areas that were involved. Some people developed PTSD just from watching the continuous news coverage, right, of what was going on that day. And so the remembrance of these events, they produce, feelings of intense distress along with anxiety, nightmares, flashbacks to the event. And those are generally recurrent. And it's, think about, our veterans and things like that coming back from, overseas, or even some of, the domestic experiences that they have had, can be significant. Bipolar disorder is when a patient experiences episodes of extreme sadness, hopelessness, and helplessness, with interspersed with periods of extreme elation and hyperactivity. So they have the episodes of major depression with at least one episode of manic or hypomanic behavior. Lithium, your mood stabilizers, right? Those are the most effective treatments for bipolar disorder. When we look at education for lithium, anybody remember lithium from pharmacology? um, what are some of the patient teaching that we need to do for lithium? Anybody remember?
I know, like, monitor their sodium. They want to, like, generally, not limit. They can be generous with their salt intake.
Very
Um,
good.
and the toxicity level. It's a
Very good.
narrow level.
Exactly. Normal salt intake. They want to make sure that they're drinking plenty of fluids. They don't want to become dehydrated, right? So, 300, or I'm sorry, 2,500 to 3,000 mLs per day. Take it with meals. It tends to cause some gastric upset. So encourage them to take their lithium with meals. Avoid caffeine. caffeinated drinks, like your energy drinks, coffee, things like that. Um, Caffeine is a natural diuretic, right? It's going to make you urinate more. So it's going to pull more fluids off. It has that diuretic effect. So have them avoid that as much as possible. And then tell them that if they have any diarrhea, any vomiting, tremors, lack of coordination, those things need to be reported immediately. Um, but yeah, lots of education when it comes to lithium, right? We know sometimes too with those medications for bipolar, schizophrenia, right? We, being compliant with those medications is super important. With eating disorders, the goal of treatment for eating disorders is to restore nutritional health and a normal body weight, with the long-term goal of being for them to achieve a sense of self-worth and self-acceptance that is not exclusively based on appearance, right? And we know, and if you've learned about eating disorders and med surge, they can be devastating to the client, right, as well as to family. So that also very non-judgmental approach when we're working with patients that have eating disorders. When we look at substance abuse, alcoholism, so alcoholism is associated with your B vitamin deficiencies like folate, low magnesium, low potassium, iron deficiency, anemia. They're prone to malnutrition, right? They may skip meals, right? Because alcohol is absorbed better on an empty stomach. The more they drink, right, the less they're going to eat. It is an central nervous system depressant, right? So it can lead to drowsiness, respiratory depression, lethargy, confusion. Um, and so how do we, blood alcohol, when we look at BAC or blood alcohol content, it's determined by the concentration of alcohol in the drink, how fast they're drinking or the rate that they're drinking, and then the rate of absorption. So if we're eating, right, we tend to absorb alcohol a little bit slower. It's also the rate of metabolism, right? Some metabolize alcohol faster than others, and a person's weight and sex. Weight, the heavier you are, right, the more it will take to, have an effect. And generally males can drink more than females do, or can drink more than females can to, get the same effects. Did I say that right? But generally men can, drink more alcohol. The amount of alcohol the liver can metabolize per hour is about a quarter of an ounce of whiskey, about 4 ounces of wine, and about a 112-ounce beer. So, think about that. How many of us, or I don't drink, so like, but how many people, when they go out, how many drinks do they have in an hour, right? So body can't, metabolize it as fast as some people are drinking. When we look at alcohol withdrawal, the when they're going through withdrawals, one of the early signs of withdrawal can be irritability. So one of the priority care things that we need to worry about is prevent the client from harming himself or others. So we want to provide a nice low stimulating environment, help maintain the client as calm as possible. We're going to monitor their vital signs closely. We also may need to reorient the client to reality, address hallucination therapeutically. I'm trying to think. But yeah, irritability, anxiety, agitation, those are usually those first early signs of alcohol withdrawal. So that's why we maintain that nice little quiet, non-stimulating environment. trying to think what else. Once the, client is stable, and they can, participate in a treatment program, therapy is confronting the patient's denial, encouraging self-diagnosis. Um, Group therapy helps to break through the denial. It gives the client a new sense of belonging as well as identity. And then, of course, the behavioral therapy will help with, self-discipline, as well as discouraging impulsive behavior. They also, talked about the deficiencies with alcoholism, maintaining adequate nutrition, adequate fluid intake is going to be really important, as well. I don't know if anybody has ever, worked with alcoholics, um, working in long-term care. Generally speaking, I deal with the effects of long-term alcoholism, right, as they get older, and the effects that it has on, the body with the liver, and sometimes even the kidneys. And so, the long-term effects can be, or be devastating on the body. Um, look at nicotine. Um, we do have a decrease in adolescents that are smoking, but what we do have an increase is in those e-cigarettes and those vapes. The oil is dangerous to young children. The vapor causes lung damage in young people. There's also still secondhand vapor exposure that is associated with health problems. And they haven't really been out that long, so really we don't really know, what long-term effects are of the e-cigarettes and the vaping. But the priority teaching, right, is the safety of e-cigarette use. Um, you know, Adults use them, not just adolescents, but adults use them too, but making sure that the oil is kept away from children. Again, it is poisonous to them. Um, and then the parts are not also safe to handle. I don't know a lot about vaping. I've never vaped. I'm not sure, but I've seen people do, they have they're like rechargeable or they have batteries or something like that in them. Um, so they can get warm just because they have batteries. So keeping them away from kids. Um, Lung damage can occur from the secondhand vapor with your e-cigarettes as well. So again, making sure that they're staying away from kids. The risk of addiction and lung damage. Is also there. Um, with tobacco, um, cigarettes, smoking is associated with cancers, lung disease, heart disease. It's the leading cause, it's one of the leading causes of bladder cancer, which I thought that was always interesting. Secondhand smoke is more toxic, leading to the same conditions. And there's plenty of stories out there, like when you listen, people that have never smoked but have had the exposure to secondhand smoke can develop the lung cancers and things just like if they had smoked. Um, Children exposed have higher rates of respiratory and ear infections, asthma attacks. Infants born to smoking mothers have higher risks for SIDS, low birth weight, premature birth, as well as stillbirth. So encouraging them not to smoke, providing education, especially when they're young, right? Getting in and providing the education about avoiding, cigarette smoking, the vaping, that kind of thing is super important. When we look at cocaine and amphetamines and methamphetamines, these are central nervous system stimulants. They are associated a lot with our cardiovascular complications. They generally will exhibit high body temperatures, high heart rates, high blood pressures, which require emergency interventions. Um, Frantic, excited speech are also symptoms of clients abusing amphetamines. Um, And so even things like when we look at amphetamines and other things, um, I worked in pediatrics for a while too, and one of the concerns was, kids that have ADHD, and have access to, their Ritalin, their Adderall, whatever, right? Instead of using it for themselves, they give it to other kids, which also potentially increases risks, right, in that population. So making, understanding what those signs and symptoms are, is important. And then we talked about a hospice, death and dying, and palliative, or hospice and palliative care. So what are the stages of grief? Can't even say it. Grief.
I'm trying to remember.
Denial,
Denial.
acceptance,
Hmm.
um, what is it?
I know it's like, can't remember them in
Right.
order, but I can remember.
No,
Anger.
yeah,
Uh,
anger and
so anger.
Bargaining.
yeah,
Bargaining.
bartering.
Bargaining.
So denial's first, right? This isn't
Hmm.
happening. They made a mistake, right? They read the test wrong, right? Um, what's bargaining?
It's when they
It's
be
like,
like,
go ahead. Go ahead.
it's kind of when they just say like, oh, if you let me live longer, I'll try to do this or I'll do
I go
that.
to church every Sunday, I promise, right?
Yeah.
Yep, I'll be a better person. I'll do all these wonderful things. Yep, absolutely. And then anger. Anger, when you think about it, right? I mean, when something happens, anger is just a normal, response to a lot of situations, right? And so that is a normal thing, right? To be mad. They get mad at others, they get mad at God, they may get mad at their doctors, their nurses, right? Um, and so, I mean, it can be very difficult to handle, right? Because they're mad at you and you really haven't done anything, right? But we do have to understand that that's a normal part of that process, right? And we have to allow them to express their feelings. And then they get into the acceptance, right? Um, and so, acceptance is, it doesn't mean that they're like, okay, I'm going to die and that's, the end of it. But they realize that, you know, it is what it is, right? It's not going to change the situation. And so, they learn to, what are they going to do, right? What treatments, are they going to follow through with? How do they want to live out the rest of their life? And it doesn't necessarily mean it's a life-threatening illness either, right? It could be something even smaller. It's how they perceive the situation, right? So that's another thing that we have to remember. In this case, when we're talking about death and dying, obviously it's a more terminal. But I have seen people go through these stages being diagnosed with asthma, with being diagnosed with diabetes. Um, a lot of people, even to this day, consider diabetes like you know, a, a terminal illness, and it's not. It's not terminal, right? We know people can live with diabetes, right, for their whole lives and not have issues, and some people have more issues. Um, so it just depends on how they, respond to the situation. And so when we go into it, what is the purpose of hospice? Like what is hospice?
It's basically to make them comfortable, like with their pain. Like my aunt recently went through it. She actually requested hospice because she was hurting so bad. So she just wanted like hospice to come to the house. Just to
Okay.
check. Yeah, check every 3 times a week. They would come check her vitals, check everything.
Mhm.
But yeah, it's basically for pain, to in my opinion, to make them
Right.
comfortable.
Absolutely. It's death with dignity, right? It's death with dignity. And pain control is absolutely one of the main focuses of hospice. Um, and so, when we look at hospice as well as palliative care, we want to improve their quality of life. We want to alleviate suffering, and we want to improve those end of life experiences for their clients as well as their families. Um, and I've worked with hospice too. I had a hospice nurse with my mom, and they are wonderful people. I don't know how hospice nurses do it. Um, because, I mean, I work in, long-term care is my passion, pediatrics and long-term care are my passions, right? And so I deal with, death and dying a lot working in long-term care, but a lot is different than all the time, right? Having hospice nurses kind of do it. And so I have a lot of respect for people that can do that. I have a hard time when I lose, a resident. Um, and so, yeah, it's just a different experience, but I like Cecily, I've worked with, my mom had a great hospice nurse that was just absolutely amazing. And that's the goal, right? Allow them to maintain dignity and autonomy as much as possible, throughout that whole process. And so, you know, how do we, help to maintain autonomy for our patients when, they're in hospice or they're receiving palliative care? This is something that's really important. What do they want? What decisions do they want to make regarding their care? Um, and so we don't want to make those decisions for them. We want them to, make as much decisions and be as involved as much as possible within their care. Um, this is a rough time for families as well as the clients, right? And so having a good, great nurse out there that can kind of work them through the process. I'm it's interesting when you see it from both sides. Um, I've also worked with um the corporate side of hospice, right? Where they come out and they're trying to sell their services. It's just so different from when you see both sides, right? Like we're the best hospice organization, right? Choose us kind of thing. Um, it's just really interesting. And then when you meet the nurses, and it's just like a completely different experience. But there's lots of services that hospice can provide. It's not just the nursing, right? They can send the nursing assistants. There's volunteers. There's chaplains, there's social workers, right? So there's a lot of different services that can be provided to these patients. I can't say it. Generally, when we look at patients going into hospice, they generally have a terminal diagnosis, right? Usually it's 6 months or less. Um, They also, depending on the hospice, they will help. I mean, they all help with the family, but some even provide services after death, like grief counseling and things like that, or follow-up care, for the families afterwards as well. Spiritual practices, also help to give meaning in life and influence how people tend to react to crisis. So that's why, they usually have like some sort of a, um, clergy or chaplain, that will, be part of that healthcare team as well. Or of course, we can reach out to whoever their church leaders are, whichever church, religion or whatever that they prefer. But the nurse needs to really focus on the needs of the client to make sure that they're comfortable, that they're maintaining dignity as well as self-esteem. The client shouldn't be kept sedated, right? And this is where and as a non-hospice nurse, right, when we work with some of our hospice patients when I work with some of the hospice patients, right, it's like the morphine and the Ativan, right? Like how often do you really give it, or when should you give it? It's always those, those really fine lines that we have to work with. Um, it's just it's an interesting concept. We don't want them sedated. We want them to, participate as much as possible. Obviously, as they get more towards the end of life care, they may become unresponsive and, be sedated themselves. Remember too, as when patient is dying, right? The hearing is the last sense to go, right? So encouraging the family to still talk and participate in that care is really important. Um, the So some of the priorities, again, when we're working with our hospice clients, um, is symptom management, comfort care, pain control is that priority, as well as, any GI or respiratory distress, um, making sure that they're comfortable, that they're, maintaining their dignity, their self-esteem, guidance, spiritual support, um, The, shoot, I forgot what I was gonna say. Um, I forgot what I was gonna say. I apologize. All right. Sorry. And so how do we know that the client is reaching end of life? Anybody know? What are some of the things that we'll see,
It's like
at,
the decrease in urine and sleeping a lot. And what else? The pulse rate goes
Modeling
up
of the
too.
skin.
Mm-hmm.
yes, all of those things, right? Difficulty swallowing, right? They may kind of go into,
And low appetite. She don't want
Mhm.
to eat.
They'll stop eating, they'll stop drinking, decreased urine output, the modeling on the skin, you'll see it especially around the knees. And then, the breathing changes. They have that Cheyne-Stokes respirations, which is like they'll breathe and then they'll have periods of apnea and then they'll breathe again. It's just very shallow breathing followed by periods of apnea. They also may have some edema, especially in their extremities, that occurs as well. So it's, having your, not only preparing your client, but preparing the family with those situations is really important. Just so that they know what to expect, right? Because kind of having, an idea of what to expect helps to ease the situation, right? Rather than just always facing the unknown. Um, Even with patients that are in we look at autopsies and things, a coroner will investigate a death where there may be a question of cause of death, like if they're not under the care of a provider, if it's a suspected suicide, or even deaths from injury. So we, depending on what state you are, and I don't remember what states they have it. What is it? The assisted suicide laws. What is it? They call it something and I can't remember what it is. Um, and those are different depending on what states, but generally nurses, right? We don't hasten death. Okay, that is not our job. Um, and so, in some states, right, some patients have the option to choose, right, almost, what is it, like a euthanasia kind of thing, right, where they choose that option. We look at spirituality and culture. Culturally competent care requires that we have an understanding of our own culture, right? And any biases or stereotypes that we may hold. We need to approach everybody as unique, without making any assumptions. We don't put our culture before others. What's the term for placing our culture above others or thinking that ours is the best?
I know what you're talking about. It's not enculturation,
Mm-mm.
right? That's getting to know your culture. I don't remember. Yeah.
Yeah, if I see it, I'll know I gotta see the word. And I don't know it if
I
I
love that.
see
Like,
it. I can't get the word either.
okay, you guys are so funny. So I'm gonna give you a minute, think about it. Culture. Think of all
Is
those
it like
terms.
Indonetri? Is it what is it? It's
Ethnocentrism.
some. There you go. There you go. Something like that.
I'm like, endo, what?
Endo. There you
That was
go.
so funny. I was like, no, it's not endometriosis, I promise.
Oh my God.
Can you guys still see my screen? I was moving stuff around. This thing is getting in my way. Okay. So yes, we want to try to avoid that ethnocentrism, right? So, and we also have to consider, excuse me, some of those traditional health practices in the plane of care, right? And so doing our cultural assessment is really important. What do they prefer? What are things that we can require or that they want to include in their treatment? You know, so do they have, do they use faith healers? Do they use oils? What are some things that they incorporate, culturally into their care? Again, as long as it is not dangerous to them or is going to impose anything on, other people in the unit or what, around them, then generally we can, incorporate some of those things into their care. Sorry. Um, and so, think about like your Jehovah Witnesses, it's always the one people remember, right? They can have surgery, they can, have care, but they generally are not going to accept blood products, right? Your Jewish population and their kosher diets, right? How can we, incorporate that into their plan of care and making sure that we're being considerate of that. Um, Native Americans, right? Um, everyone, I should say every culture, right, has their own food preferences and, things that they like to, that are important to them that they, have in their everyday lives. When we look at culture as well, too, right, we have to also take into consideration um language barriers, right? That verbal and nonverbal communication, right? How, the use of personal space, the use of touch. We have to understand that. And what's some of the best ways that we can understand another person's culture and their desires and their, specific request? How do we identify those things?
By asking
Ask the
them.
patient.
Exactly. Ask them, right? We don't treat every client the same, right? Nor do we treat them the way we want to be treated, right? Be based off of how our culture is, right? So we need to, you know, ask them what their preferences are. It's not sufficient to learn common beliefs of only the most common minorities. We need to learn about all of the different cultures. Um, and then try to look through the world, look at the world through their eyes and what their experiences are in life and how we can make it better. Um, we have patients that we're working with that don't speak our language. What's the best way to interact with that population? How do we work with clients that don't speak English?
Interpreter.
Interpreter. Right. Usually tend to use professional interpreters, right? That's usually our best option, right? We try to avoid using family, friends, children as interpreters, unless it's an absolute emergency and we don't have another option at that time. Um, Regarding time, cultures are future, past, or present oriented. So your past oriented cultures value their ancestors and the past, and can sometimes have a preoccupation with past events that make it difficult to achieve future goals. Your present oriented cultures are, they value the here, the now. They prioritize quality of life, and making decisions that can make them happy now in the present, right? Which that can lead to decision making that fails to plan for the future, or consider future consequences. Future oriented cultures are more likely to make sacrifices in the present in order to achieve future or long-term goals. And so again, then cultural competence is attained when the nurse makes a conscious attempt to learn about people of different cultures and look at the world through their perspective. When we look at ethics and legal issues, and so that first step of that process is, right, to identify the ethical issues that are faced. And so we have our ethical principles of non-maleficence, beneficence, distributive justice, and autonomy. And so what is non-maleficence?
Do good, basically doing good, not basically hurting the patient.
Right, do no harm, right? Beneficence is to do good. What is justice?
To treat equal,
Right, to
treat all
treat
patients
people
equal.
equally, right? Treat everybody the same. And then autonomy. Autonomy is super important, right? Um, as long as they are making their decisions and they are fully informed, right? We need to respect their rights, right? Whether it's to refuse treatments, to refuse a medication, to stop treatments, right? If they I think of probably one of the hardest things that I've had to, and well, not the hardest, but one of the hardest things I've watched is someone stop their dialysis, right? That's probably one of the hardest things that I have watched. Um, and so, right, but that's their decision, right? As long as they're fully informed, right? They make that decision autonomously. They have that right. And so, that's part of that autonomy. I can't remember the other word. It'll come to me in a minute. So give me an example of beneficence or doing good.
And like still giving a hospice patient pain medication.
Okay, yeah, right. Yes, adequate pain
Treatment.
control, right? That is beneficence. Yep. Um, with distributive justice, that could be something like advocating for insurance coverage of hospice service or another service, right? That we can help to, provide. Of course, that non-maleficence is to do no harm, right? Whenever possible. And so that's our basic nursing judgment, right? Down to like following the rights of medication administration, right? Making sure that we're not doing anything that we don't know how to do. Documentation. Following guidelines for appropriate documentation, right? Make sure that it's factual, that it contains descriptive, objective information about what the nurse sees, hears, feels, and smells. Do not use inferences without supporting factual data, because it can be misunderstood. You want to avoid vague terms like appears. That just kind of shows that, we're stating an opinion. So I remember, just as an example, um, this is a really long time ago when I was like a brand new LPN. Um, you get into the groove, right? And you start using some vague, unfortunately, you use some vague sentences, right? Um, you know, patient or, patient lying in bed sleeping. Well, how do you know they're sleeping? Right? Just because they're laying in the bed and their eyes are closed doesn't mean that they're sleeping, right? Um, so we like started to write patient lying in bed, eyes closed, right? To avoid inferences, right? Because just because somebody is laying in bed doesn't mean that they're with their eyes closed doesn't mean that they're sleeping, right? So that's kind of one of those examples, right? I know it sounds, because we assume that they're sleeping, right? Doesn't necessarily mean that they're sleeping. So you have to kind of, be a little bit more objective in how you write it. Um, Another ethical legal issue, floating from one unit to another. That is an acceptable practice used by hospitals, right, to help with staffing issues. Legally, the nurse cannot refuse to float unless they have a union contract that says they can't float. I don't know. Okay. Um, I will post a recording, so you'll have it. Um, so, I don't know how many states have unions, honestly. I don't think I've ever worked in a state that had a nursing unit. But anyway, so unless the union contract says that they can only work in a specified area, right? And then when faced with that situation, nurses should identify potential areas of harm to the client and identify tests that can be safely performed, right? So I think in class I use like, a med surg, nurse being pulled to labor and delivery, right? Like what do you do, right? But in, a situation, what are things that you can do? We all have basic nursing knowledge, right? And so there are potentially things that we can assist with, right? That may be beneficial. Or you can outline the fact that, it could be potentially detrimental too because you don't have an understanding. And then our week 6 was occupational environmental health. Children are more vulnerable to environmental hazards. These exposures are more likely to lead to adverse health outcomes, even during fetal development. And then, even as they get older. So, the environmental hazards should always be considered in nursing care when we're working with our pediatric patients. Um, when you look at your occupational health nurses, um, your employee health nurses, right? Nurses can go conduct assessments of the workplace. They can learn about work processes, what materials are used in that area. And it's not just nursing, right? They're looking at environmental services, dietary, um, therapies, right? All of the different disciplines within the organization to look at any and identify any actual or potential hazards, the work practices of the employees, right? How often do you wash your hands when you're there at work, right? As well as observe the effectiveness of safety education and equipment. The occupational health nurse is going to see injuries, diseases that we can acquire right throughout our employment because we know that no work is completely risk-free, no matter where you work, what you do. There is always going to be risks involved. Whether, even from minor to serious injuries can occur. And then the last little bit was our client teaching, reinforcing health education barriers to learning. So one of the most important learner related barriers is low literacy. And so we a lot of times will deal with patients and individuals, populations, who are illiterate or have low literacy levels. There are still plenty of people here in the United States that cannot read and write. And so, they may be embarrassed, right? To admit that they can't read or they can't write. And so, how do we determine if somebody can read? How do we know? How can we determine somebody who can read?
You can give them something like instructions, something to read, see if they can.
Give them something and ask them to read it to you. Um, and so, that will tell us, if they can read or not. And then how do we overcome it, right? We have to be able to provide them education so that they can take care of themselves, whether it's, a return demonstration, right? Using more pictures versus, words. Making sure that we are providing that education to them so that they can take care of themselves. Your different, you guys remember the, um, what is it? The 3 levels of learning or the 3 different types of learning?
During the auditory, visuary, and I don't remember.
The cognitive,
Kinesthetic,
the
right?
affective,
Okay.
and the
Or
psychomotor. So
it's
what is
been
cognitive?
the way of the, how they think of like
Thinking.
It's
what they're going through basically.
that's
Or
a
if they're or if they're learning something, like the way they think about it, have they thought it through? Do you understand?
Process out, yeah, understanding it and comprehending it.
okay. I'm like trying to figure out where we're going with that.
Yeah.
Okay. I was like, because I think like it's like you're combining. I'm just trying to see. I'm gonna try something. Because I don't want to mess you up either. So cognitive is the thinking part of the person, right? The ability to hear, to read information, understand it, memorize it, and then use it later to solve problems. Your affective is the feeling part, right? That's the attitudes, the feelings, the behaviors, the values, that all affect their ability to learn. And then the psychomotor, right? That's the moving part. So they learn a skill or a task through actual practice and experience, right? This is where I said, even in nursing school, and I worked with, students on campus, right? The see one, do one, teach one is very effective with psychomotor, right? You have them watch you do a task, then you let them do the task, and then they teach somebody else to do the task, and it just reinforces it. Um, if you're, not hitting all 3 of those domains, then, the education may not be as effective, right? So things like making a change, right? If you tell somebody that they need to make a change without telling them why they need to make the change, right, you're going to be less likely to have them make that change. So we have to address kind of all 3 of those. And so when we look at, I'll just do the, primary, secondary, and tertiary um prevention for education. So like primary would be, teaching the importance of immunizations, right? What diseases are prevented with immunizations. Teaching parents how to role model, healthy eating. Teaching women to avoid before and after sex to prevent urinary tract infections, right? Those would be primary prevention for education. Secondary, would be education for colonoscopy perhaps, right? Scheduling your pap smears, scheduling your mammograms, right? Even teaching, the signs and symptoms of what a urinary tract infection would be. That's a self-screening process, right? And then tertiary is, teaching that DASH diet to the patient with hypertension or the low sodium diet for somebody with, hypertension, how to use a glucometer for a diabetic, you know, and then giving them pamphlets on the signs and symptoms of hypoglycemia. You know, the potential side effects of, you know, certain medications, that patient teaching that we're going to provide. You know, you come in, they are diagnosed, we start them on some medication, right? And then we have to do that patient education regarding that medication. So, all right, so that is that is exam. What exam are we on? And that is your review for exam 2.
Because I was in 3. I had to know for 7. I said, I don't remember going over this. I hope it's not on the exam.
Oh my
And then I
gosh.
looked in
I'm
and was
like,
like, oh, it was for the next, it was for exam
that's
3.
the next one. Yeah. All right. Do you guys have any questions for me?
Then it's pretty much laid out what I've been going over, so
All right.
yes. Is there anything we should be asking that we're not?
Oh no, no, not that. No.
Okay. But thank you.
You're welcome. You guys have a
Yeah,
great night.
you
You
too.
too.
All right.
Bye.
Bye.